Welcome everyone again. Another episode here, Doctors of Podiatry. What is plantar fasciitis? What is plantar fasciosis? One of the most commonly clinical presentations that we treat, not only here at Doctors of Podiatry, but all the podiatrists all around the country and all the orthopedic surgeons all around the country. Heel pain, right? And when we're looking at the algorithm, heel pain, right? Heel pain can be caused because of A, B, C, D, E. We're not going to talk about all of those. We're going to talk about one cause of heel pain, which is plantar fasciitis or plantar fasciosis. I'm going to make this really, really simple for everyone, okay? So, there's three stages, right? I like to categorize them. Number one, acute. Number two, subacute. Number three, chronic. I was just talking to the patient. How do we define this, right? Just to make it very, very simple, we'll say acute, maybe less than 2 months, right? And then maybe subacute, maybe 2 to 4-ish. And then 5, greater than 5, right? And these are months, right? Sorry about my penmanship. Months. So that's how, that's the algorithm and protocol that I use to decide what's going to be best for the patient and what's going to work best for the patient, right? Talking about outcomes, right? My job is to heal patients. So the patient was here several weeks ago, and we really didn't do a whole lot. We did speak about the different stages: acute, subacute, chronic. This patient has been battling this problem 2 years. 2 years. 2, not 1, not months, 2 years. So what's the problem? Clearly, the patient falls into what category? The chronic. So we did speak about something that we do here, which is called a percutaneous microtenotomy. It's a microneedling procedure. It works great in conjunction with platelet-rich plasma therapy, the PRP therapy, which we're essentially isolating the blood, right? We're spinning the blood. The blood separates into good and bad. The bad we throw away, the good we keep, which has all the platelets, and the platelets in turn contain, just to keep it very, very simple, the growth factors, the cells that aid in lowering inflammation and regenerating the damaged tissue, right? That's number one. Option number two that we discussed, the minimally invasive plantar fasciotomy. A what? A plantar fasciotomy. So it's very simple, right? We're looking at the bottom, right? At the bottom of the foot. This is the ligament. And just like hand surgeons treat carpal tunnel syndrome, right? When people here, patients have numbness in these, usually these 3 fingers, it's because that there's a very important structure there that's pressing on the nerve. And when the structure presses on the nerve, people feel numbness. So what do? The hand surgeons go in there and they basically release the ligament, and all of a sudden, the numbness or tingling or any of those symptoms go away. So what we essentially do is that's the analogy that I give patients. So we go in and we make right around here, right, in the skin, make a tiny, tiny, tiny little incision. You can see here, this is the ligament, right? Oh boy, I'm gonna get in trouble for this one. We're gonna go ahead, we make one little stitch, we go in there and we release, just like the hand surgeons release, right? We release about, just a little bit of the ligament. Some people, depends on who you ask, 5, 10, 15, 20% of the ligament, doesn't matter. What we essentially do is we release the ligament. And in releasing the ligament, we're releasing the tension. And if we're releasing the tension, we are reducing inflammation. You guys with me? Good. So, this patient has elected, obviously she's here back, and she doesn't want to look back before she makes a commitment, whether it be for the minimally plantar fasciotomy, right? And I want to make it I just want to say something. This procedure we do here in our office-based surgical suite under local anesthesia. We not only do this, which is where we snip the little ligament a little bit, but we also implement the PRP there. But the patient doesn't want to look back, right? So she's here today because she wants to try, even after 2 years in the chronic stage, she wants to try these 2 injections of cortisone. Okay. A little steroid injection into both. Very, very little. We're not going to go all bunkers here, right? Just a small amount to see what happens, right? Because and I kind of want, and I do agree with her. I don't want the patient or any patient looking back and saying I should have tried this before this, or we're just following the algorithm. So without further ado, we're gonna perform these injections under ultrasound guidance, right? I always like to use the ultrasound. I'm gonna go ahead and clean this, clean that. I always tell the patient that no one likes an injection. They're gonna feel just gonna make sure that no one's okay, perfect. So I like to use the ultrasound always. And by the way, in my experience, in chronic stages, a lot of people may say, well, more volume is better. Let's inject 3 cc's or 4 cc's, right? More. It doesn't really work like that. What we're essentially doing is we're just injecting just enough to find out if we can just alleviate some of that discomfort. Okay? So without further ado, right? Okay. I'm gonna ask no one. Pop goes the weasel. Okay. 1 second here. Here we go. You're gonna feel a little stick. The only thing I ask is please do not move your heel. Okay, and we look at the ultrasound, we're in the right spot. And now we're gonna tell the patient that they're gonna feel a lot of burning. And again, I know a lot of people that like to really just infiltrate this as quick as possible. I personally don't, and we're done there. Just like that. Nice and slow. We'll put that right over there. The patient is smiling at me. And again, we use our ultrasound here. Everything looks, we're in the right location, and the patient is going to feel cold spray as we speak. Good. And but sometimes we're using a very small needle, and here we go. And I don't like to just jam the needle into the heel because, believe it or not, the needle can break. It's a very, very small gauge needle, and just like that, we come out. Okay? So we're done with both injections. We're gonna keep this segment very, very short, and we'll definitely follow up on this patient to see what will happen from this point during the course of the next 2 weeks. Okay, and then we can do another segment on other types of clinical presentations that cause heel pain. So I just, of course, I always like to thank all my patients. www.jawspodiatry.com. You okay? Okay, good. www.jawspodiatry.com. Facebook, Jaws Podiatry. Instagram, Dr. Toe Jam. And lastly, for all the YouTubers out there, thank you for following us. I hope you guys continue to enjoy all the videos that we're putting out. Jaws Healthcare. Have a wonderful day.